Hello and welcome to the topic Cardiomyopathies in the Cardiology module. By the end of this session, you should be able to define cardiomyopathies, classify cardiomyopathies, outline the approach to making a diagnosis of cardiomyopathies, and finally discuss the treatment of cardiomyopathies. Let's get started. So, what is cardiomyopathy? As the name indicates, cardiomyopathy refers to a group of myocardial diseases which describe a variety of issues that result from disease of the myocardium. Cardiomyopathies are largely classified into primary and secondary types. Primary cardiomyopathies are the diseases of the myocardium that develops by itself, and secondary cardiomyopathies develop to compensate for an underlying disease such as hypertension or valvular heart disease. For the primary type classification, the cardiac muscle diseases predominantly involve the myocardium, usually genetically linked such as hypertrophic myopathies, arrhythmogenic right ventricular dysplasia, glycogen storage disorders, and mitochondrial myopathies. When we look at acquired causes, this includes inflammatory cardiomyopathies, peripartum cardiomyopathies, and tachycardia-induced cardiomyopathies. For the secondary type of cardiomyopathy, the myocardial disease is secondary or associated with a systemic disease, or in other words, develops following an underlying condition. Infiltrative cardiomyopathies include amyloidosis. Storage cardiomyopathies include hemochromatosis. Toxicity cardiomyopathies include toxicity due to drugs such as chemotherapy agents. Inflammatory cardiomyopathies include sarcoidosis. Endocrine cardiomyopathies include hypo or hyperthyroidism and diabetes. And finally, we have autoimmune myopathies, which include systemic lupus erythematosus, rheumatoid arthritis, and scleroderma. Most of these types of cardiomyopathies take the form of dilated cardiomyopathy phenotypically. Let's dive into the first type, which is dilated cardiomyopathy. It is the most common type of non-ischemic cardiomyopathy, and it accounts for 90% of cases. What happens here is that all four chambers of the heart are dilated, but the left ventricle more so than the right ventricle. The form of hypertrophy that we see here is called eccentric hypertrophy, where sarcomeres are added in series. The heart wall becomes thin and they lose contractility. This leads to predominantly systolic dysfunction. The most common cause of dilated cardiomyopathy is idiopathic, where it is usually unknown. Other conditions to look out for whilst working up the cause of dilated cardiomyopathy include myocarditis caused by infections such as HIV, Coxsackie B, diphtheria, Chagas disease, of course ischemic heart disease, peripartum cardiomyopathy, long-standing hypertension, iatrogenic causes as seen in the use of doxorubicin, substance abuse such as in the case of cocaine or alcohol, and rarely infiltrative causes like sarcoidosis and hemochromatosis, and finally, inherited diseases that predisposes one to dilated cardiomyopathy, such as seen in Duchenne's muscular dystrophy. So, what would you expect to see in a patient with dilated cardiomyopathy? Look for classic findings of heart failure or insufficiency, as you may also hear a systolic murmur, which indicates the stretching of the valves resulting in mitral and tricuspid regurgitation. Next would be hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is the leading cause of sudden cardiac death in young athletes. It usually is due to a mutation in the gene encoding beta-myosin heavy chain protein. Echo findings include mitral regurgitation, systolic anterior motion of the anterior mitral valve, and asymmetric septal hypertrophy. Among the specific symptoms or features of hypertrophic cardiomyopathy are syncope, palpitations, and in worst-case scenarios, sudden cardiac arrest. Next is restrictive cardiomyopathy. This form of cardiomyopathy is commonly observed in tropical regions. Contrary to dilated cardiomyopathy, restrictive cardiomyopathy is a diastolic malfunction caused by an increased rigidity of the heart's wall due to the increased connective tissue leading to increased pressures in atria and ventricles. Common infiltrative diseases that lead to a restrictive type of cardiomyopathy include amyloidosis and sarcoidosis. This condition can also be caused by certain drugs, specifically chemotherapeutic drugs such as anthracyclines. Other causes include post-radiotherapy and Loveless endocarditis. Cardiac MRI and a transvenous endomyocardial biopsy are done to establish the diagnosis and also to look at the severity of the disease pattern. Next would be arrhythmogenic right ventricular dysplasia or cardiomyopathy, which is an inherited cardiomyopathy characterized by structural and functional abnormalities in the right ventricle, resulting in ventricular arrhythmias. So, what happens here is the right ventricular myocardium is replaced by fatty and fibrofatty tissue. It is an important cause of sudden cardiac death in young adults, accounting for half of all cases among athletes. Palpitation is the most frequent symptom and is caused by ventricular arrhythmias. Depending on the disease severity, ventricular ectopics may be isolated or may result in non-sustained or sustained ventricular tachycardia, ventricular fibrillation, and sudden cardiac death. Progressive right ventricular dysfunction results in dyspnea and leg swelling, and in more severe cases with left ventricular involvement, patients may present with biventricular congestive heart failure that may mimic dilated cardiomyopathy. Exercise can induce ventricular arrhythmias and sudden cardiac death. There are a few changes on ECG that can be expected in a patient with arrhythmogenic right ventricular dysplasia. ECG abnormalities in V1 to V3, typically T wave inversion. An epsilon wave is found in about 50% of those with arrhythmogenic right ventricular dysplasia, and this is best described as a terminal notch at the QRS complex. The T wave inversion in the precordial leads exploring the right ventricle, and there could be sustained or non-sustained left bundle branch block type ventricular tachycardia. The next type of cardiomyopathy we'll be looking at is known as Takotsubo cardiomyopathy and is a temporary heart condition that is brought on by stress. It is also called stress-induced cardiomyopathy. Example, when the patient just found out the family members have died, then develops chest pain and features of heart failure. It has the same symptoms as a heart attack, but it's not caused by any underlying cardiovascular disease. Takotsubo cardiomyopathy most often affects women between the ages of 61 and 76 years. The condition commonly occurs immediately after experiencing extreme emotional or physical stress. These stressors cause sustained rise in catecholamines, leading to intrinsic changes of the myocardium. And these effects eventually lead to epicardial spasm, myocardial dysfunction, and myocardial injury. Features include chest pain, features of heart failure. You may also notice ST elevation on ECG, however, normal coronary angiogram findings. The treatment is supportive. Next would be peripartum cardiomyopathy. This type typically develops between the last month of pregnancy and 5 months postpartum, more common in older women with greater parity and multiple gestations. The outcomes of the patients with peripartum cardiomyopathy depends on the pre-delivery ejection fraction. If the ejection fraction is less than 30%, the poorer the outcome is. This is a diagnosis of exclusion, and it's important to exclude other causes of cardiomyopathy such as valvular heart disease, ischemia, an existing congenital heart disease, dilated cardiomyopathy, and spontaneous coronary artery dissection. Serial echocardiogram is recommended post-delivery. The diagnosis of cardiomyopathy begins with history. Usually, the patient's symptoms consist of complaining of fatigue, weakness, and shortness of breath. The first task is to ascertain degree of cardiac impairment, and this is done by assessing the severity of the symptoms and how these have affected their daily activities. A more objective evaluation can be done by using the NYHA classification. Physical exam and echocardiography may provide more information on the severity of the condition, which then helps determine the approach to management of the disease. Once the condition is more under control, next is to ascertain the cause of the underlying cardiomyopathy. Noting the presence of other underlying illnesses such as sarcoidosis, amyloidosis, thyroid disorders, and rheumatoid arthritis can be helpful in determining potential causes of cardiomyopathy. Social history, including smoking, alcohol, and drug abuse, can also be helpful in making the diagnosis. Family history is often important, especially if there's concern about sudden cardiac death at an early age. Lastly, is to start considering the measures that will benefit the patient long term. Long-term goals are to prevent progression of TEND disease as well as to reduce remodeling as much as possible. Some cardiomyopathies can cause sudden cardiac death, so pertinent measures are to be taken to prevent these events. Before we come to the end, let's look at a few principles of management of cardiomyopathies in a whole. So management is broadly divided into medical and procedural ways. Medical therapies such as using ACE inhibitors or ARBs are useful in preventing further cardiac remodeling. Usage of diuretics is also beneficial in cardiac failure. Cardiac failure secondary to dilated cardiomyopathy is treated using diuretics, vasodilators, ACE inhibitors, and beta blockers, which delay the progression of the disease and lowers the risk of sudden cardiac death. Such treatment also aims at improving cardiac function as well as alleviating most of the symptoms. If arrhythmic side effects occur, the implantation of cardiac resynchronization systems are indicated. As for HOCM, you may begin the patient on beta blockers, calcium channel blockers. There could be alcohol septal ablation, myomectomy, and implantable cardiac defibrillator. This condition is treated with beta blockers or calcium channel blockers. In severe cases, alcohol septal ablation and myomectomy are also considered. An implantable cardiac defibrillator is placed to prevent malignant arrhythmias, which can lead to sudden cardiac arrest. Restrictive cardiomyopathy treatment include medications like diuretics to reduce preload and ACE inhibitors or angiotensin receptor blockers. Calcium channel blockers are contraindicated due to their negative inotropic effect, particularly in cardiomyopathy caused by amyloidosis. Procedural therapy in the likes of implantable cardioverter defibrillator and cardiac resynchronization therapy can be done if patients meet specific criteria for these therapy. If there has been an event of cardiac arrest before, it is a strong indication for an implantable cardioverter defibrillator to prevent future episodes. So in summary, cardiomyopathy refers to diseases of the heart muscle. Cardiomyopathy can be largely divided into primary and secondary causes or based on its pathology of disease. As cardiomyopathy worsens, heart failure or arrhythmias ensue. The main types of cardiomyopathy are dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy, arrhythmogenic right ventricular dysplasia, and another type is called stress-induced cardiomyopathy, also known as Takotsubo cardiomyopathy. The diagnosis is established with the aid of echocardiography, cardiac MRI, and sometimes endomyocardial biopsy. Treatments include medical therapy, surgery, implantable cardioverter defibrillator, or cardiac resynchronization therapy to correct arrhythmias. These treatments can control symptoms, reduce complications, and prevent the disease from worsening. So we have come to the end of this topic. Thank you.